Some specific pathogens in community-acquired pneumonia. Regarding Streptococcus pneumonia or pneumococcus, it's the leading bacterial cause of community-acquired pneumonia. Symptomatic nasopharyngeal colonization with the pneumococcus occurred in 50% of the children aged 2 to 3 years and 10% of adults. Pneumococcal pneumonia classically present with acute onset of high fever and pleuritic chest pain in young adults, although atypical pneumonia are common, particularly in elderly. Susceptibility factors for pneumococcal disease are smoking in age below 2 years or age above 65 years, viral respiratory infection, including antecedent influenza, recent acquisitions of new virulent strain, poverty, overcrowding, childhood daycare, chronic disease such as chronic obstructive pulmonary disease or chronic obstructive pulmonary disease, asthma, diabetes mellitus, cardiac or renal or hepatic failure, alcohol excess, aspiria, including sickle cell chronic lymphocytic leukemia, including sickle cell disease, primary or secondary immunodeficiency, such as in HIV, myeloma, or chronic lymphocytic leukemia, complement deficiency, and so on. Regarding viral causes of community-acquired pneumonia, surveillance studies with enhanced diagnostic testing demonstrate the presence of respiratory viruses in a significant proportion of patients hospitalized with community-acquired pneumonia. Human rhinovirus appears to be particularly common, although its pathogenic role is unclear. Influenza A and B are also commonly isolated. Regarding Legionella species, Legionella pneumophila is the most common cause of human disease, divided into more than 15 serogroups. Serogroup 1 is the most prevalent, but nearly all serogroups can cause human disease. Legionnaires' disease, it's a pneumonia caused by Legionella species, is traditionally considered to cause only high severity CAP, but can cause low moderate severity community-acquired pneumonia in more than 50% of cases. It can be acquired sporadically or during outbreaks. Susceptibility factors for Legionella pneumonia include the following: increasing age, male sex, smoker, smoker, alcohol excess, chronic lung disease, lung cancer, end-stage renal failure, end-stage renal disease, diabetes mellitus, immunosuppression, hematologic malignancy, HIV, solid organ transplant, use of corticosteroids and chemotherapy, and anti-tumor necrosis factor alpha. No specific features are diagnostic for Legionella infection, although altered mental status, prominent neurological or gastrointestinal symptoms, abnormal liver enzymes, raised CK, and hyponatremia are commonly reported. Mycoplasma pneumonia typically affects younger patients with prominent extrapulmonary involvement, including hemolysis, cold agglutinins, hepatitis, skin and joint problems. May cause primarily small airways infection with tree embed nodularity on CT chest. Staphylococcus aureus occurs most commonly in winter months, often suggested by recent influenza-like illness. Coincidence influenza infection is common. Community-acquired multiple resistant Staphylococcus aureus MRSA pneumonia is increasingly recognized, and risk factors include hospital admission or antibiotics in the previous 90 days, recent influenza-like illness, hemodialysis, previous methicillin-resistant Staph aureus colonizations, congestive heart failure. Panton Valentine leukocidine-producing Staphylococcus aureus infection characteristically causes high severity of community-acquired methicillin-resistant Staph aureus pneumonia, often in previously healthy young adults. It's typically associated with a rapid development of lung necrosis and cavitation with multi-organ failure and carries a high mortality. If strongly suspected, inform ICU and discuss with microbiology and add linezolid 600 mg BID intravenously, clindamycin 1.2 gram 4 times a day intravenously, and rifampicin 600 mg BID intravenous. Other pathogens include Chlamydophila psittaci or psittacosis infection acquired from birds and animals, with 20% of cases having a history of bird contact. Human to human spread may occur. Coxella burnetii or Q fever epidemics in relation to animal sources, usually sheep or goats, but occupational exposure only present in minority of cases, often dry cough, high fever, and headache. Chlamydophila pneumonia may cause epidemics in the community, unclear if has a direct pathogenic role.